Hello, my name is Sherry Whelan, and I'm an RN with the Division of Developmental Disabilities State Quality Assurance Team. And the following orientation training was designed for registered nurses providing the home and community-based waiver service of residential monthly RN oversight. This overview will be used by your local quality assurance teams as part of your orientation, and it's a introduction for both nurses and for DMH contracted providers so that they can understand the role of the nurse in providing residential RN oversight. We first want to provide a brief introduction to the organizational structure of the Department of Mental Health. The department is made up of two divisions: the Division of Developmental Disabilities, which we refer to as DD, and the Division of Behavioral Health, which is referred to as DBH. At the bottom of the screen, you'll see the website where you can, the department website, where you can find more information on both divisions. The Division of DD was established in 1974 and serves individuals with developmental disabilities occurring before the age of 22 and who have substantial limitations in their ability to function independently. The division works to improve the lives of persons with intellectual and developmental disabilities to lead independent and productive lives. In 1988, the division began participation in the Medicaid home and community-based waiver, and the division administers 4 waivers, and those are showing on your screen. We serve approximately 14,500 individuals currently in the DD waiver, of which, of course, that's a fluid number and varies in any point in time. Of that 14,500, approximately 7,400 individuals receive residential services through the comprehensive waiver specifically. The monthly RN oversight service is a service that's provided in residential service settings under the comprehensive waiver, and that's what we'll focus, the waiver that we'll focus on today. It may help to also understand that when we refer to a waiver, it is a waiver to the Missouri State Medicaid plan and allows for Medicaid coverage of for a defined service and a defined population beyond the basic state Medicaid plan. CMS stands for Centers for Medicare and Medicaid Services, and CMS has provided states with additional guidance in March of 2014 in regards to the delivery of home and community-based WAVE services, and that guidance emphasized health and welfare outcomes, and the registered nurse in the role of RN Oversight Services plays a key in assuring health and welfare of individuals through the delivery of this service. Monthly RN Oversight Services includes functions such as evaluation and monitoring of individuals, risk mitigation, and the application of healthcare standards. You're going to be provided with additional resource links throughout your orientation, but healthcare standards frequently utilized are from the National Institute of Health, or also referred to as NIH, the Centers for Disease Control and Prevention, also referred to as CDC, Healthy People 2020. We also frequently connect with the Office of Licensure and Certification, who provides guidance and standards for home and community-based waiver. And the nurses frequently get a lot of guidance through the Developmental Disabilities Nurses Association. And all those links will be provided for you later in this overview. The CMS provides, with this additional guidance, has some sub-assurances to assure the health and welfare of individuals. There are multiple quality assurance functions that support the sub-assurances under the health and welfare. And we want to talk about the role of the RN providing oversight and assuring the health and welfare. So nurses are already mandated reporters, and the RN providing this RN oversight and monitoring has a role to assure health and welfare of individuals served. The RN in these positions should be given access to event reports that are generated by the organization that they work for, and this will assist them in monitoring for multiple things, including abuse and neglect, restraint, and exploitation. These review of the event reports help keep the nurses informed of events that occur when they are not present and allow you to determine if appropriate actions and follow-up have been taken to resolve the situation, as well as determine how to prevent reoccurrence of events when applicable. The RN may also access a more comprehensive collection of incident management data through your quality assurance RNs at your regional office. Following this review, the QERNs in your region will review some directives with you. Particularly, you should get information on event report processing, which is Division Directive 4.070. There's the Code of State Regulations, also referred to as a CSR, for report of complaints of abuse, neglect, and misuse of funds and property. There is Division Directive 4.300, behavioral support requirements, which includes restrictive interventions, restraints, and seclusion, and time out. And Division Directive 4.200, due process review committee for limitations of individuals' rights. These are all directives and CSRs that you should be aware of, and which are designed to help support the health and welfare of individuals we serve. The residential service may be the residential service itself may be provided in a variety of settings, and we're going to focus on two models of delivering residential services where the monthly RN oversight services are delivered. One is an ISL. It stands for Individualized Supported Living Arrangement. And ISLs are typically small, like 1 to 3 individuals living in a setting in the community, and they have individualized supports, which may be up to 24-hour staffing or a combination of supports. The ISLs are typically owned or rented by an individual rather than the residential service provider. And each person in an ISL has a budget, which is associated with reflecting their room and board, and includes the RN oversight service. In a group home, where residential services may also be provided, is organized differently. Group home services are delivered in a larger setting, typically 4 to 8 people, but is still a home in the community. The group homes are typically owned by the contracted service provider instead of the individual. And group homes are established with a monthly rate for service, like a per diem rate. And those things will come into play more in the discussion as we talk about how services are authorized, because they are different between an ISL and a group home. The difference in how the nursing services are authorized, we'll talk about each of these briefly. In the ISL, the monthly RN oversight services is authorized on an annual basis for each individual. Annual corresponds with their ISP year, which is an individualized support plan. That's the authorizing document. It corresponds with that ISP year and is typically at a rate of 1.25 hours per month, but definitely cannot be less than 30 minutes a month per person. The nursing service is specific to the individual, and the authorized time may not be combined or shared with other persons that may live in the ISL. Only services that are delivered are then billed, but have to be prior authorized. After delivering the required monthly oversight services, and we'll talk about more about what that is in a little bit, but once that requirement of that service is delivered for the person, any unused authorized hours for that person may be carried over from month to month within the authorized time frame, which is the ISP year, as long as they do not exceed the total annual authorization. Now, this is important because it's a little bit different in a group home, how that's delivered. And the other part that you see on your screen is when you look at the waiver manual, this is the code that represents nursing, the monthly RN oversight nursing in an ISL, the service code, and how those units are billed. In the group home, the monthly RN oversight service is built into the group home rate, which is based on the 1.25 hours per month per individual receiving services from that contractor provider. And it is specific to the group home site. So one organization may run multiple sites. They may have multiple homes. So the consolidation of hours is within that home. And the group home hours may be combined and distributed based on an individual's needs as long as the required monthly RN oversight function is met for each person. So for example, if there were 4 individuals living in a group home, they were authorized, they would be authorized at 4 times the 1.25 hours for a month. That's a total of 5 hours a month for that site, which is then added to the provider's monthly rate. The nurses are still responsible to log and account for their time in the delivery of the service. Any unused service, however, for that month may not be carried over to another month. The total authorized hours of that 5 in that example start over each month. The nurse is expected to deliver that nursing oversight service to each individual. So each individual has 1.25 hours. If one person did not require all of that 1.25 hour time, any balance of that time could be provided to another individual who in that month may be needing more time to complete the service for them. They may be more medically involved, have more going on that month. So that's how that time can be combined within the month, within the authorized amount. And that is different than the ISL. It is an option for the nurse to deliver the monthly oversight service in the group home using the same model as in the ISL, keeping the hours distinct and separate. But there is no flexibility on the ability to carry the hours over, so there's still no unused hours are end of the month and are not carried over. And we'll talk more about that. Individuals, regardless of whether the monthly RN service is delivered in the ISL or the group home, there is a process for requesting additional nursing services, both RN and LPN, when a person's healthcare needs exceed the service hours that are authorized. So we have to think about this nursing oversight service is a foundational or minimal service that's provided for all individuals receiving residential service. when an individual's needs medically exceed that, then we have a process that additional nursing services may be requested that are above and beyond this 1.25 hours. When a person does have the need for more hours, the need needs to be specific to that individual, described specifically for that individual, and needs to be documented in the person's individual plan. That may be done through an amendment if it's mid-year, and must be authorized through the utilization review process, which is explained in another directive, but you'll be getting more information on that. The maximum amount of units that you can bill or that can be authorized, rather you can only bill what's authorized, so the maximum allowed here is reflected at it's 48 hours, and those are 15-minute increments, so that's up to 12 hours a day, if it can be justified medically. There is also a utilization review worksheet that's new and available, and nurses can be very helpful in helping individuals complete that form and help translate that medical need into words that non-medical staff would better understand why you're asking for additional nursing and what that nursing service is exactly that's needed. You may need to help estimate the length of time that the service is needed, why it's needed, and helping evaluate the need for that service to continue. The QERNs at your regional office will also be able to provide you with that form and the link as on the DMH website. There are a few additional notes about monthly RN oversight service in general that I just wanted to talk about briefly. The monthly RN oversight, again, also known as a community RN, or previously known as a community RN program, it is a unique service provided under the ISL and group home services, but I wanted to point out that this is only a name change in the program. The change in the name to monthly registered nurse oversight, the functions are the same, but the title has changed to align with the terminology used in the Medicaid waiver. The program itself is specific to RNs, even though many of our providers utilize LPNs in their organizational structure. The program is specific to RNs because in Missouri, LPNs may not work autonomously and must work under the oversight of an RN or a licensed physician. So in order to assure that some providers may only have this monthly RN oversight nursing service within their organization, that may be the only nursing they have, and there are certain functions that needed to occur, so it was designed that it would have to be an RN. So that's why you'll see the reference to that even within a lot of our information. So just know that the name has changed, but the service has not changed to date. A few other things is very important to know and know about this delivery of this particular service is that the service through the waiver must not supplant existing Medicaid state plan services through either the Medicaid or Medicare for any individual. So if there's a service already available through another source, we don't want to duplicate that through the waiver. So if straight Medicaid is going to pay for something, we would access that first before we would have a nursing service covered through the waiver. Another example would be that there's an exclusion of services for diabetes self-management training because that's available under the state plan. Medical nutrition therapy services are prescribed by a physician for a person who is Medicare eligible. You would access that as opposed to something that the nurse may be doing for that person who is diabetic or has renal disease. An individual may also be eligible to receive other nursing services in their home, such as home health services or hospice services. Both of those other nursing resources may come into the home. And the important part here is that we just don't duplicate services, that we keep each person has their own function, and we do not duplicate service. And that requires some coordination and planning, of course, to work well, but those are frequently used in individuals' homes. The other point I think is just to mention regarding the fact that the residential service says are required to provide up to 1.25 hours of nursing oversight with a minimum of 30 minutes. A nurse who's in this position, it may feel more like a consultant because they are coming in and out at different times, and all the other staff providing services may not present at all times when you may be there. But it is very important that regardless of whether you're employed or you're contracted, that regardless of how you're connected with that organization, when you deliver the service, you're very much part of the individual's team, and you do have responsibilities for helping with the planning and the oversight of the services being delivered. So, it's very important that you become familiar with the ISP. You may not be present at a meeting, but that you may be able to call in, or you provide your information through your monthly monitoring documentation so that the team can consider that and make sure that plans are in place to address a person's needs. You want to become familiar with what your own organizational structure is, so that you'll see what a key part of communication, or how important communication is in making sure that once you've identified a need, that those needs get met and addressed through the organization. The nurses may also identify that this service model kind of resembles home health, because you may be going in an ISL, so you're going into that individual's home, and services are being delivered in their home, but yet there may be 24-hour staffing, and there certainly are standards of care that are expected to be met. So it's kind of a middle ground between home health and a more medical model like a skilled nurse setting. It's a combination of the two. And so it is a very different model in how we deliver services in nursing. As I previously stated, that although the name has changed, the community RN service for residential multi RN oversight has not. And we want to talk about what makes up that service. You'll see on the screen that there's some highlighted words, some that most nurses would be very familiar with: to evaluate care, to plan for supports, to provide physical assessment, to assess the environment, and then to actually perform complex nursing treatments. Those are all part of services that the RN providing the services may provide during the delivery of service. We want to focus on some activities that must be present in the delivery of the monthly RN oversight service. The National Institute of Health, or the NIH, recommends that the delivery of healthcare for individuals with IDD or intellectual and developmental disabilities be a multidisciplinary approach that's proactive, preventative, and anticipatory. And this is really the design of the residential monthly RN oversight service. There are particular activities and functions that are required components of the delivery of the DD monthly RN oversight service as it pertains to the evaluation and monitoring of individuals' care. One is the monthly face-to-face RN assessment of an individual. We get a lot of questions about this, exactly what does this mean, and people interpret assessment to be different things. So we want to spend a few minutes talking about that. Certainly when an RN comes into this position or you meet an individual for the first time, you want to plan for completing a complete nursing physical assessment, head-to-toe assessment, so that you have a baseline in which to identify an individual's needs and assure that proper supports are in place and can plan for that individual. This is also recommended following a person's discharge from a hospital or other settings, which rehab or things in which they are transitioning from one level of care to another. Once that baseline assessment is there, or a repeated head-to-toe because of a transition, that should be followed up on a monthly basis with assessment and monitoring for the areas of need that have been identified for that person. So once you've done your head-to-toe, you may identify what that individual's risk areas are and assess more closely around those risk areas. The nursing assessment itself will include a monthly evaluation, not just of the individual, but also related data collected by possibly other staff who've been trained to do such things. I mean, that may include, could be a blood sugar record, a weight record, looking at blood pressures, your GJ tube feedings, the full gamut of information, so that of support that's being provided on a daily basis. Part of the RN providing oversight's role is to take that data, look at it, making sure that evaluating how that individual is responding to that service. Are the services being delivered as trained? Is the individual getting everything they need to address and support their needs? The physical assessment is not a, I want to clarify, it is not a walk-by assessment. That is never sufficient, okay? So just because you lay eyes on the individual does not meet the expectation for providing a monthly assessment for that person. And of course, this would all be documented, and we'll talk about documentation in a little more detail further in the overview. But so that's a little bit of introduction on the actual nursing assessment. But another part of that monthly review is that, as I said, you're going to be looking at the data that's being collected, or the services that are being provided for that individual when you're perhaps not there, or being done by other people. And also you want to look at all the medical and health information that has come in since the last time that you may have looked at that information the previous month. And that's going to pretty much always include your physician's orders, medical consultation notes since the last review. You want to look at labs, lab results, any need for follow-up of those, or any monitoring, for example, of routine labs that should be on a particular schedule. Are those, is there a process so that people know when to do those? Are those getting done on time? that kind of thing. So you're looking at the individual. You're also looking at the structure in which supporting that individual for getting these things accomplished. You would have access to your staff documentation pertaining to their observation notes and things that would be telling to you as a nurse to review of how that person is doing. Any medical treatments on, in the ongoing health monitoring, as I said earlier, seizure records, just vitals. I mean, all of the information that would be available. Note that during a review that you really should be documenting or dating and initialing when you review particular documents, because that is your evidence that you did indeed review that and you are aware of that information. Nurses in these positions should be providing nursing recommendations and providing directives with staff whenever that is needed. Nurses in particular in these roles are responsible for the medication administration oversight of medication administration programs. So you'll always be looking at new medication orders and treatments, making sure that they've been accurately transcribed to the MAR and that they are being implemented correctly. Another function, so as far as the overall functions of nurses in these positions, you have the monthly assessment, the monthly review of medical and health information, and then the third point third expectation of services, nursing delegation and oversight of an evaluation of any nursing tasks, nursing care tasks that have been delegated to unlicensed assistive personnel or LPNs that may be working in that organization that you're assigning to. So we've definitely dedicated some time in this overview to talk about the topic of delegation, but this particular slide just wanted to talk about the actual expectations of the nurse. The term unlicensed assistive personnel is used by the Missouri State Board of Nursing and basically describes for us any time that we have paid staff. So the expectation is you're paying them to deliver the service. So we have paid staff who are not licensed but are being asked and trained to carry out a nursing task. That person is the unlicensed assistive personnel, and they may not be referred to, and they probably won't be referred to in any given setting that you would work in. They're not going to be called UAPs, but they may be DSPs, direct care professionals, direct support staff. They go by a variety of titles, which is also an important thing to be aware of, because the titles also, the variation in titles also reflects that the titles are not standardized throughout the state. They do not necessarily represent an equal level of training from one organization to another. And that's very important for a nurse to be aware of when they are providing oversight of individuals and assigning them nursing care tasks. The RN is responsible for medication oversight of the medication administration program that's being administered there in the home. That's typically done by, they will call them medication aides. That falls under the umbrella of unlicensed assistive personnel in Missouri, and we'll talk about this under delegation, but in Missouri, the Nurse Practice Act specifically, it doesn't have a laundry list necessarily of what kind of tasks are nursing tasks and which are not, but it does list medication administration as one of the nursing care tasks specifically. So we know that would require the staff to be appropriately trained by designated staff and before they would be given that responsibility. Again, we'll get into that a little deeper. Nurses in these positions are responsible then for the delegation of nursing care tasks and for providing the ongoing oversight and evaluation of the delivery of those tasks, which include medication administration. And then as a result of those functions, they're expected to provide monthly reporting, monthly documents of the findings that they may have through the course of those activities. Before we get, I guess, into delegation, I wanted to also mention that from the previous slide that the monthly RN Oversight Summary Report is a tool. It's a document where you will be able to reflect all those findings. Your QERN will share more information with you about that document. And we'll talk about documentation, but that's where you will provide that evidence of delivery of service. Okay. We want to talk a little bit about what is delegation, because one of the expectations of the RN providing the service is to delegate and supervise nursing care tasks that are assigned to unlicensed staff. Medication administration is certainly one of those. So delegation in itself is a management tool. So used effectively, it can result in safe and effective nursing care. The act of delegation is the act of transferring to a competent individual the authority to perform a selected nursing task in a selected situation, and that's a definition from the National Council of State Boards of Nursing. The decision to delegate a nursing activity or task to another person is the decision of the professional nurse and cannot be mandated of them. And I can't stress that enough. With medication administration, we have a process in place for the certification of medication aids, and we expect those individuals to meet that minimum threshold before they would be considered for assignment of medication administration. But even though we expect that they should be utilized that way, it would still fall upon the nurse to choose to allow that individual to administer, to determine that they do have the necessary skill sets and are able to follow their training and perform that task safely. The same with any other nursing care task that may be performed. So if the nurse would identify for any reason that they are not comfortable with the delegation of a particular task to a non-licensed person, they should work with that agency and provider to address that issue. So a nurse cannot be forced to delegate a nursing task. It's very important that nurses be aware of their own scope of practice that's defined within the State Board of Nursing. And it's also defined by your own experiences and abilities. Nurses who are not current in a particular skill set, and that might be a need of an individual, also needs to speak up for themselves, perhaps, and to get that additional training or update so that they can better support the individual and support the staff to support the individual. An example might be an individual who might return from the hospital and now have a significantly higher level of care. And if an individual might come back with a trach or a vent and that nurse does not know how to support that skill, they would want to prepare further with training so that they can then assure everything is in place and support the staff there. Agencies should also encourage and involve the RN when planning is occurring for individuals, that when they're going to consider bringing an individual into a group home, for example, or they're going to support an individual, that if they would involve their nurse, the nurse can help them utilize their skills in determining whether necessary supports are in place for an individual who has a particular needs a particular skill set, and the staff need a particular skill set to deliver that service. So it's really important that the nurses stay engaged, again, not just as a consultant, but as a team member, and be aware of what's happening with individuals, both new individuals coming into a home, individuals transitioning back from the hospital, and that they will have an opportunity, because they are overseeing staff that are delivering those services. So they want to make sure that the staff have appropriate training and necessary supplies are in place, and whatever is needed for that person. This is also, as I said in the beginning, the nurses in these positions should be given access to event reporting for that agency, because event reports are completed for medication errors, they're completed for ER visits and hospitalizations, injuries, health, and all of these things help the nurse stay on top of what's happening when they may not be present. It helps them understand better the changes in the individual's level of functioning or their needs, and it helps for planning for that individual to assure that both the individual's needs are being met and staff needs for training are being met. I've had the pleasure of working with Deborah Funk, who's the practice administrator with the Missouri State Board of Nursing, and she's we've done some trainings together around the state, and she has permitted us to share a few of her slides, and this is one of those slides that she uses during her presentation on the topic of delegation. The slide quotes the Missouri Code of State Regulation, which is actually establishes the authority for an RN to delegate to an unlicensed assistive personnel who, as you will discover in our settings, go by other titles such as direct support professionals, direct care, first staff, but basically, again, any unlicensed person who's paid to perform an activity, that is the nursing care staff. That's what makes them an unlicensed assistive personnel. But you can see from this slide that a registered nurse may teach, delegate, and supervise licensed practical nurses and unlicensed healthcare personnel in the performance of certain nursing tasks. So that's the authority to be able to do that, and that's cited through the Nurse Practice Act, which is reflected on this slide, and this is the definition for the professional nursing, and this is also a slide from the state board, and and when Deborah Funk does this training, she points out that the teaching and supervision of other persons in the performance of the above is actually the act of delegation, the teaching and supervising of individuals in performing any nursing care tasks. The basically teaching and supervision, when you look at the state board information, you'll see that the nursing and supervision are used in lieu of the actual word delegation. The National Council of State Boards of Nursing is also another great resource if you're interested in reading more about delegation. The monthly, so we basically have just touched on the fringes of talking about what delegation is. So, but we want to talk more about the role of the RN providing delegation of nursing care tasks in the setting of the monthly RN oversight role. There are some things that I want to make sure that the nurses are aware of. The residential service organizations may vary in the orientation structure for the staff in what they are prepared for in delivering, quote, direct care staff delivery services. So the nurse that has responsibility for delegation needs to be able to identify what the special instruction is, they identify the nursing support that's needed, identify the staff who are competent to perform that specialized task. They will need to ensure that that specialized instruction is provided or obtained. They don't necessarily have to be the ones to always provide it, but that may be obtained by an appropriate source, and that is documented with evidence of competency. And then they need to provide that ongoing oversight of that assignment. All of those activities make up delegation, and it's important that if you're going to delegate to staff, that you know what that staff's background or training is, and the fact that, as we said earlier, they may go by different titles, but that title may reflect different things and is not necessarily standardized. As you become familiar with your own organizational structure, you know, these things will become more apparent. You'll know what the orientation is included for your direct care staff. But if contract providers are obligated to make sure their staff are CPR and first aid certified, so that should be in place. And the division or the department requires that before a person would be assigned medication administration, that they be either a DMH med aid or a DHSS trained med aid. So that's a minimum level of a training. And they might also be a certified med tech through the Department of Health and Senior Services, or could be a licensed nurse or medical professional who has the authority to administer medication. So the point here, I think, is that not all titles are created equal. Staff do not always know what their official title, may be in regards to even medication administration. They're going to go by different names, or different organizations may go by different names for staff in different positions. So just do a little homework, become aware of what a title represents and what that training represents. Not all direct care staff are certified nurse assistants, so they're not, like Department of Health and Senior Services has a CNA and certified nurse assistant, and so that prepares individuals for the delivery of direct care services. So when someone says they are a direct care staff, that may not be equivalent to that what you may be familiar with is contained in that course of training to get that certification. So just know that the titles may vary and the training associated with any given title may vary. They're not standardized at this point. Let's see. How does a nurse decide which task needs to be delegated? Generally speaking, when making the decision of which activities are appropriate for or to be appropriate for consideration to delegate, the decision making needs to typically include these activities. So asking the questions, are these tasks that are frequently reoccur in daily care for an individual? Do they require staff to exercise any nursing judgment? Because you cannot delegate nursing judgment. they typically are tasks that do not require complex or multidimensional application of nursing process. You can't delegate that. They are tasks for which results would be predictable and the potential risk is minimal, and tasks which utilize standard and unchanging procedures. So it's step 1, 2, 3, 1, 2, 3 every time. Person knows what to do, knows when to report if something isn't in accordance with those steps. So the act of delegation is determined by the delegating or overseeing nurse on an individualized basis, and it's specific to the identified nursing task. So what is it you're asking them to do? What is how stable? You have to take that into consideration, along with how stable is the individual. Is this something new for them? The consumer, is this a new, are they newly diabetic? Is this a new G-tube? Are they well established and they are stable? In addition, you have to also take in consideration the ability of the staff. Are the staff confident in what they're doing? Are they comfortable with what they're doing and with their training that they've received? Have they had enough supervision before you back off of that and have them do that on their own? So there's a lot. That's why this has to be such an individualized activity and at the discretion of the overseeing nurse. So there's a lot that goes into delegation, which sometimes makes nurses maybe nervous, but they shouldn't be, because there's a lot. It's very clear cut. And one of the things that again Deborah Funk would say during her training is, who is practicing under your license as a nurse? And frequently the audience will say, well, those direct care staff are. But the answer to that question is, who is practicing under your license is nobody but you. You are the only person truly practicing under your license. So I hope that will alleviate some concerns about delegation, because as stated by the Missouri State Board of Nursing, the unlicensed healthcare personnel remain personally accountable for their own actions. The nurse is held accountable for how they made their decision to delegate. So what that means is basically we have to make sure that the components for delegation are present. So when you are going to assign someone there, to a nursing care task, well, what is the task? Where did the person get their training to do this? Did the former staff person that was doing it train them, or did they actually get this training from a nurse or another licensed person, maybe the respiratory therapist, maybe the physical therapist? Where did the training come from? Where's our evidence of that training? We always need that to be, we need that evidence. How do we prove it, that they were trained, and when and on what? Because if something would be questioned, let's say something bad did happen at something that an unlicensed or direct care staff person did or didn't do, then the questioning would be, what were you trained? Did you follow that training, and if not, why? That's how an individual is held accountable for their own actions. For the nurse, why did you decide to delegate it? Because it was an appropriate task. You have your rationale for why you decided to delegate, and then the other parts of that is, was that person trained? Yes, I saw they had their Med-A certificate. They passed at the threshold that was expected, and I've been monitoring, periodically. I provide the general oversight. I haven't seen a lot of EMTs. Things were going, correctly, and as we could expect, you had no reason to withdraw that delegation. So it's not all on the nurses' shoulders. The nurses are, however, held accountable to their decision to delegate. This slide on delegation highlights the components involved in delegation, as I was just speaking to. So briefly, the bold section, licensed nurses must ensure that unlicensed healthcare personnel have documented, demonstrated evidence of appropriate education, training, skills, and experience to accomplish the task safely. So delegation components are made up of the training, the competency of that individual. So we got to show that they were, at that point in time, competent on the information they were trained on, and the actual assignment. Now, the assignment may be done in the form of a delegation, an actual written delegation form, which we'll talk about, or it can be the fact that you were put on the assignment for the medication administration on the schedule today. With all that. So you're assigning, you're transitioning that responsibility to them to do that task. And then the other part, which we really have to do a lot of work on, is the ongoing oversight and evaluation of the assignment of that activity. So how are they doing with that? How is the individual doing with that, having a non-licensed person perform that task? So that's something that we do on an ongoing basis throughout, from month to month. As I said earlier, that the Nurse Practice Act does not necessarily have a laundry list of what a nursing care task is. They do specify medication administration is identified in the Nurse Practice Act as a nursing care task. When we asked the State Board of why the Nurse Practice Act did not give us a list of tasks, what was provided to us was that nursing is an outcome-driven, knowledge-based process discipline that in context dependent and requires critical thinking. So nursing cannot be reduced to solely a list of tasks. So the licensed nurses' specialized education, professional judgment, and discretion are essential for quality nursing care. And that's why they do not list just a list of tasks in our State Board of Nursing. The Missouri Nurse Practice Act defines nursing standards and identifies medication administration as a nursing task. And in addition to this, other state regulation and agency policies may apply and may be specific or it may specify other requirements or limitations. So you need to become familiar with your agency's policies along with other state policies and federal regulations that could impact delivery of service. An example would be for a contracted agencies, DMH requires that before a nurse can delegate the task of medication administration, at a minimum, the staff must first be an active certified med-aid, either a DMH med-aid or have received their training as a level 1 med-aid through DHSS. So the provider organization may have additional requirements on top of that that might say, for example, that a new med-aid must pass so many supervised med passes or for a certain amount of time before they're allowed to take on that responsibility, or that the nurse has to sign off before they can be put on the schedule, or lots of different policies that might influence you moving forward with when you delegate or how you delegate. But the decision to delegate certainly remains with you. Delegation of a specified, there is a form called Delegation of Specified Nursing Tasks that your QERNs will be sharing with you. And sometimes nurses are not, we get asked a lot of questions about, well, why do you have to have a delegation tool? Why do you have to have a form that shows the delegation? And I'm hoping that that is clearer now than it might have been in the beginning, but the work that's done in the individual's home is the individual's home, and it is not a medical model such as a hospital or a skilled nursing setting. And so not all nursing care tasks are written are written because the staff involved have a standardized scope of practice. So in a hospital, for example, or a nursing home, you may have a certified nurse aide. You know what their skill scope of training is. They are use LPNs and RNs. You know what that scope of training is, so you know what they can be assigned, and then you just provide that ongoing supervision. So a lot of that is done without a paper trail of necessarily showing you delegated this to this person. It may just be reflected in who's assigned to who on what day and that kind of thing. But in the variety of DD settings that non-licensed staff may be assigned nursing tasks, there is not one regulated title or certification for a non-licensed staff. That would provide that assurance, of the standardized training and comprehension. And the only exception to that is the DD medication aid certification. That one is standardized. So therefore, any nursing care tasks that are delegated to a non-licensed staff require that evidence of what the training contained, their competency, the assignment, and ongoing monitoring. So the nursing care, or this form called Delegation of Specified Nursing Tasks, that form allows you to identify the needed information for delegation, so that the form has, it's consumer and task specific. It has a place for you to reflect the delegation or the activity was assigned, and or that you have rescinded the assignment. It's important too to know that any delegation to unlicensed staff can be rescinded at any point in time. The nurse can rescind that. They've given them the authority to do it. They have the authority to pull that assignment back. Also, you need to be aware that delegation is not transferable. So if a staff starts to work in your organization and they formerly worked at another organization and they say, well, I was trained on that before, and that nurse said it was okay for me to do that. That was under that nurse's watch. You're now providing the oversight, so you would need to validate that training, who provided it, that person was competent and that you want them to do that task, whatever that defined task is. So when there is a change in the RNs, for example, that are providing monthly oversight service, it's the new RN coming in. It's their responsibility to assure that there is the necessary documentation available that demonstrates that staff have received that training and were deemed competent to continue performing that task. During the absence of an RN, it's important that no new tasks be assigned to staff without benefit of that nursing training and oversight, or that new staff coming in don't pick up on any, don't get assigned any nursing care tasks until they have the benefit of that nursing training and oversight that are all part of delegation. A common question that we get, since we do have the delegation form, is do we, and that is the most common, medication administration is the most common nursing care task assigned to direct care staff. And so the question always comes up, do we have to have that form for assigning medication administration? And you do not. Medication administration does not require the completion of the delegation form, as long as what the medication aid is being asked to do is within the scope and training of their certification, of their Med-Aid certification. So, for example, for a DMH medication aid administering oral medications would not necessarily require additional documentation of training and competency, because that is within the scope of that training. However, if they were asked to administer medications through a G-tube, that is not within their scope of training. So that would require additional instruction, and you would use then the form for documenting that what training was given and that you are assigning that task. Any RN that's providing monthly RN oversight services who is not familiar with the basic Med-Aid curriculum, you would want to become familiar with what that scope contains, and you can get that additional information from your QERN at your regional office. It's also important to know that the nurse who provides oversight may not be the same nurse that provided the training for a staff. For example, in Med-Aid, you have a certified Med-Aid instructor who may or may not be the same nurse who's going to go on and provide supervision for that staff. So training can come from a variety of appropriate resources, and sometimes tasks needing to be assigned can come from, you know, other sources, a nutritionist, a hospital nurse, a therapist, but you still need evidence of what that training occurred. Another thing to keep in mind is that when a person has not, even if they've been trained, when a person has not utilized that skill set for a while, they may still require review and support. So do keep that in mind. If somebody, oh yeah, I'm certified in this, or I've received training in that, how long has it been since they've used that skill? They may have been competent to perform it at that point in time, but may not have retained it or have lost some of those skills since they received that training. You know, we really need to be better at training our direct care staff and teaching them to not accept assignments if they have not received training and or no longer feel competent to do so, because you'll, in all the documentation around delegation, you notice the competent word is used quite frequently. So you know, in order to be competent, you also need to be confident. So staff need to be not only have the skill, but feel comfortable in using that skill, and should be able to voice that if they need support or additional guidance. So always encourage staff to communicate their needs and support for guidance and oversight, additional oversight from the nurse, without it being necessarily a negative thing to require to ask for help. So just in review, the only certifications at this point that are standardized by the state, regulated by the state, are the DMH Med-Aid certification, Department of Health Medication Aid certification, the Department of Health and Senior Services, or DHSS Level 1 Medication Aid certification, and those are equal in training. They use the same, at this point in time, use the same curriculum. They have the same requirements of 16 hours of training in the classroom, plus 80% or better on a written performance test, and 100% on performance, an actual passing medications. And then there is also Department of Health and Senior Services Certified Med Tech, which would also replace the need to be a Med Aid if you're a Med Tech, because that is an even higher level. It's more like 60 or 64 hours, something in that ballpark, compared to the 16 of the Med Aid. So the medication administration does not require additional delegation form if you have that evidence of the training and they're still current in those trainings, which they do. The Med-Aids do require updates every 2 years. This screen is just a listing of resources, many of which are referred to up to this point, but your QERNs will have this and some additional resources for you. But these are particular ones that are helpful when you want to familiarize yourself more with the topic of delegation. The next slide is an overview of the minimum requirements for the hiring and training of nurses who are providing residential monthly RN oversight. The nurse must maintain an active license in Missouri to practice nursing in Missouri. So the RN license does replace the need to be a medication aid or have first aid certification. That's considered part of within the scope of your RN license. The nurse must be and have maintained certification in CPR. They must receive training, as other staff are required to receive training for preventing, detecting, and reporting abuse and neglect prior to service delivery, and at least biannually. The additional training requirements that are required by contract for services for contracted service provider would be also applicable to RNs, such as HIPAA and confidentiality training, individual rights, due process, etc. So that question does come up a lot, so we thought we would go on and share that. Another thing we wanted to share is to just take this opportunity to make sure that nurses and providers know the resources available and the expectations around licensure verification of nurses that are hired. So there's a mandatory license verification in regulation that says before hiring a registered nurse or an LPN or advanced practice nurse in Missouri, an employer shall verify that the applicant has a current valid license to practice nursing under Chapter 335. And the employer shall have a process in place to verify licensure status for each nurse, et cetera, that coincides with their licensing renewal. And that law went into effect in 2010. So basically in the beginning, and then with the cycling of their nursing license. An easy way, if you're not familiar with this, an easy way to track all of that is through the website. It's called Nurses, www.nursys.com. This can be used to verify RN and LPN license. It will reflect any discipline, any expiration dates, and so on the website. The website page looks like this, and it is. You'll see that there are different tabs here, and this is important because it's important that the nurse themselves utilize this program to go in and register, and that will then you would be notified, for example, if anyone ever, let's say someone made an allegation against you as a nurse and your performance as a nurse, they would be able to contact you, they would notify you, they have a link to you so that they could inform you, and you would want to know that and any actions that might be involved with that. As an employer, separately, so the nurse needs to register themselves, but the employer needs to register all nurses that they would employ. This would give them an automatic email notification that would say, you know, this nurse's license maybe did not get renewed, or maybe there has been some action. So there's not, nurses may work in other settings and have lives outside of the organization. So anything that would occur that would infringe upon that nursing license status, then the employer of that nurse would be notified by email. So it's a really efficient system for both the nurse getting communication about their license when it's due to be renewed, you know, if there's any issues with it, and it also will do the same thing for the employer. But the important key here is that the nurses need to enroll themselves, and the employer still needs to enroll their nurses that they hire in order for that to work. The want to talk a minute about the documentation requirements for the Community RN Monthly Oversight Service. The completion of there is a document form, as I mentioned earlier. There is a monthly RN summary document that is expected to be completed. It contains sections of information that correlate with the job functions of the nurses in these capacities. And the nurses, some providers have asked if they could, for example, integrate that form into their electronic system and do other things like that, or even some nurses have expanded that document, and there were certain things they wanted to add and expand that document, which is fine for them to do that, all of those things. They just had to retain the title so that when individuals are searching for these documents, they know what it is when they see it. And we just ask that it cannot contain less than the required components. You can add on to it, but it can't take away from it. So that could result in the forms looking a little bit different between agencies, but the bottom line is that the information needs to be documented. And so it is a summary documentation of the service that's delivered. So the who, the when, the what, and the outcome. It accounts for, the nurse has to account for their time dedicated to the functions of the RN, monthly RN oversight service each month. And then, of course, the documentation of delegation, which we just talked about that. There's a separate form for that, although the oversight can be reflected certainly in the monthly summary. That all services must be documented and available as a component of the individual's record. Documentation must include individualized plan of treatment and detailed record of intervention activities by unit of service. So the individual, whatever the service is, obviously that was delivered by the nurse, needs to be reflected in the documentation. There's a long list here of resources for you that the provider, but the provider is required to follow procedures that are set forth in the Code of State Regulations that Medicaid defines what adequate documentation is, and this is a Medicaid funded service, so we comply with what those requirements are, and some of which we just talked about. The provider is required to include in their documentation, and this is reflected in the provider waiver manual, detailed progress notes by date of service and monthly progress notes that are associated with the objectives listed in the person's plan. An ISP or could be also then further defined in more of a nursing treatment plan or something similar by title. The resources for those manuals are also provided to you on that screen. The monthly documentation, it's important that you make sure that the services include your a date of service, the time, and the evidence of the service delivered, and what the outcome of that service delivery was, and then that is the service that supports your billing. I'm going to go back a screen here just a second. I want to talk just a minute more about delegation, or I'm sorry, about documentation. The nurses in this position cannot, you may hear them say you cannot bill for your billing note. So you can't bill for the time that you've spent writing your billing note, but you can bill for your write-up of your assessment and what you're doing to deliver the service. So when you when you do your nursing assessment, you provide that documentation, that's certainly billable. When you do your monthly summary, if there is a separate assessment form that you use or some other document, you are able to refer to that document, but it just needs to be very clear and easily accessible. So if an MAC comes in, they're doing their Medicaid audit, they see that this service provided on this date and this month, but you refer to a physical assessment, please see physical assessment dated, whatever, so that they can connect the dots. That's very important in your write-up to make sure that is available. The documentation really you need to make sure that it is specific to the consumer, and the nurses need to make sure that they do not have we don't want to have duplicate documentation. So we try to mainstream that, but there has to be a billing note or other documentation that if they go by different names. So some people call them a billing note, some people call them a log note, but there really has to be, bottom line, the evidence of the date you provided the service, to who you provided it to, what did you provide, and what the outcome of what you provided was. That needs to be in your note. The monthly summary tool, if you haven't revised the paper format tool that the QERNs will share with you, you will note at the top have a list of activities that may be associated with the monthly RN function. And some of the things that we had talked about early on, like checking the labs and checking the orders and checking the MARs and so on. And those were listed on the form as to assist the nurse in making sure that they didn't miss anything, that they considered all these things as they were going through their evaluation of that individual for that month. But some people have inadvertently used those little bullets as check boxes, and they really are not intended to be check box. You really need a narrative note to support your activities. It's not enough to check a box and say you did something. You must have those components of time and date of service, what was delivered to who, and what the outcome of that service was. But you do have the ability to refer to other supporting documents if you have it, so that you don't have to duplicate if it's already written somewhere else. I just wanted to point that out. A few other things that I wanted to share with you about your role as a community RN. These are not necessarily part of the community RN program, but these are all other functions that are happening around quality assurance that do touch on the role of the nurse, and that you will hear talked about, maybe asked to talk about with the QERNs, and you'll want to become familiar with what those are. The Health Identification and Planning System, also referred to as HIPS. This is a quality assurance activity that involves the health inventory being completed by the support coordinator, and this is done at least annually for individuals. It's done when a person enters services for the first time. And then it's also done, the inventory is done if there are any significant health changes throughout the year. And that, that is scored, and depending on the score of that inventory results in a nursing review that's completed by the regional office nurse. When the nurse does this, if they qualify on an annual basis, that information, the nurse review itself is available through Seymour online for the nurses to view and the teams. And then if there are any findings during that review of any of information that need to be addressed by the organization for that person, or by case management, whoever the responsible entity is, that would result in findings on a plan of action. So there's a health inventory that may result in a nursing review. If there's a nursing review, that could result in an action plan. Once there's an action plan, there's a notification process that goes along with that, so then you'll get more information on all of these, but I just wanted to let you know that's out there, and you could be involved in responding to the findings. So what should, the nurse has identified these things, what does the organization or the person, the support coordinator, whoever is responsible, plan to do to address those findings? And then that would then be monitored to completion. And then that's definitely a point of opportunity for the RN, the agency RN, and the provider, the regional office QERN to correspond and discuss needs for that individual and how to best achieve that. Another QE activity that often touches on residential RNs is the mortality review. Anytime a person in residential services, DD residential services, dies, they receive a mortality review. That mortality review has a section that's completed by the provider delivering service to that individual. Even if the person dies in the hospital, if they were in receipt of residential services enrolled in, we do a mortality review. Not to indicate that there was fault on anyone's part. It's separate from, it's not the same as an abuse and neglect type of investigation process. This mortality review is present to allow us to evaluate the death of an individual, to determine that services certainly were delivered as expected, but to also see what can we learn, how can we improve things in service delivery if there's anything to discover. So mortality reviews have a provider section that the nurses are sometimes involved in. Then there's a section completed by the regional office nursing and a committee there. And then that will be reviewed at regional office level. And then it goes on for an executive level at central office. All mortality reviews are reviewed at central office level. And then that mortality review can also then result sometimes in an action plan if things are found that need to be addressed. So that sometimes nurses are called upon to be involved with that. Another term that you may hear is clinical reviews. After certain event reports come in, the QERNs are reviewing those and may conduct a clinical review as a result of that, and may reach out to you to discuss that event or the follow-up to that event. And the objective here is as an assurance that the nurses are certainly aware of the situation, but more importantly, the organization itself has responded to that event appropriately. That not only did we address it for that individual, but we look at it to determine, is there any action that needs to be taken to resolve this so it doesn't reoccur if it's something that should not, we don't want to recur. So, did a person get the right follow-up? What needs to happen for that individual, and is that in place and planned? So oftentimes the regional office nurses and nurses at the agencies communicate closely on those, as well as other activities, because the QERNs should be a great resource for the nurses that work within the organizations. The agency plans, plan of actions do speak to individuals receiving residential services. So we don't necessarily find action plans typically for individuals who are in natural home unless it's for another paid service. So there is an authority there that action plans of actions or corrections could be put in place for individuals who are in receipt of other paid service. This slide just has some additional, again, resources for you as nurses in your capacity. one thing I want to really encourage you to do, if you've not already done so, is go to the DMH website, which is dmh.mo.gov, and under DD, sign up for the email blast. This is an opportunity for you then to get email notification whenever things are posted, whether it be something for comment and feedback regarding policies, procedures, practices, programs, things that might be put in place. It's also an opportunity to get information on upcoming trainings, webinars, anything like that that's coming out from the Department of the Division. So it's a great resource, and so we really encourage you to sign up for that. I'd also encourage you to make sure that your QE-RN at your regional office has your most current contact information, because it is very important that we be able to reach you should there be any information that needs to be shared with you about any kind of updates to programs, but also about as we move forward with our own quality assurance activities, identify trends and patterns in areas of health and wellness. We would want to share those with you as well, so that you can stay informed. So the regional office RNs will continue to provide orientation trainings to nurses within 90 days of hire, the nurses that are in these positions, and would include some of the information that we just touched on today, but they will then follow up with more details. This monthly RN Oversight service is done quarterly, but there is also going to be an opportunity for an annual meeting, and I would encourage you to watch for that and participate if you can. Each region tries to host at least one annual meeting for nurses around your entire region that are performing the same activities as you are, and it's an opportunity that these can be informational, and it's a great opportunity to network with other nurses that are delivering the same service. Typically, those have been held in the fall, just because I think that's when that got started. This is just a page I was mentioning on the email blast. This is the page, what it looks like to. It's very easy to sign up for that. And some additional resources, things that you will want to become familiar with, and we'll talk about further. But the ISP guide, the waiver manual, those are very tied to what you're doing, as we've talked about. I do want to mention PAMS, because you will see in the waiver manual that there is another nursing code called Professional Assessment and Monitoring, which is what PAMS stands for. And there's a service definition. The service definition is very similar to monthly services that you would provide in residential, but this code and name is used for nursing services in non-residential settings. So PAM nursing, professional assessment monitoring nursing, is for non-residential, and then the monthly RN oversight nursing function and code is used for residential services, nursing services. Okay. This concludes the overview. After this, the QERNs will be providing you more information, sharing the forms, and sharing the directives and references. If you have any questions about the information, please ask your QERN that's hosting your orientation. Thank you.